The visual fields are defined as the part of environment visible simultaneously to a steadily fixing eye. It is famously called the hill of vision in the sea of darkness, where the hill represents the area of retinal sensitivity and the sea represents the area of no perception. The peak of the hill corresponds to the area of maximum retinal sensitivity, that is the fovea, and it keeps on decreasing as we move towards the periphery. This sensitivity drops rapidly from 0 to 3 degrees and then drops gradually from 3 to 30 degrees and drops even more rapidly from 30 degrees onwards. The normal extension of the visual fields is 60 degrees superiorly, 60 degrees nasally, 75 degrees inferiorly, and 100 degrees temporally. Perimetry is a subjective examination method to assess visual fields. It is broadly classified into kinetic perimetry and static perimetry. In kinetic perimetry, an object is moved from the non-seeing area to a seeing area, giving us the measure of the extent of the visual field. We only get a two-dimensional measurement of the hill of vision. That means we get the measurement along the x-axis and the y-axis and no information about the z-axis. All the location where the stimulus is first seen, they have equal sensitivities, and when we join all these points, we get an isopter. Therefore, a kinetic perimetry can accurately plot the border of the defect, but it does not give information about the depth of the defect. In this, we have the confrontation perimetry, tangent perimetry, ARC, and Goldman perimetry. A static perimetry gives us a three-dimensional assessment of the predetermined point in the hill of the vision. That means not just the x and y axis, we get the depth of retinal sensitivity along the z axis also. In the present era, we have automated perimeters which provide us more sensitive, reproducible, and efficient information. There's already a statistical package, StatPack, available. There is normative data available, which helps us in comparison with the age-matched controls. With the newer perimetric test, early detection has also become possible now. Octopus 300, Octopus 101, and Humphrey 700 are the basic automatic perimeters available. In automated perimetry, a constant sized stimulus against a constant background illumination is presented in variable light intensities at particular points according to a testing strategy, and the minimum intensity necessary for the detection of the stimulus is recorded as the threshold of that point. This is the descriptive definition. Does that sound confusing? Let us take it one at a time. What is this constant size stimulus? The size of the stimulus was given by Goldman. There are 6 sizes: Goldman size 0, 1, 2, 3, 4 and 5. 0 is 1 by 16 mm square and it goes up to 64 mm square. The size 3 is the standard. 5 is used in severe defects. Whether it is 3 or 4, it is going to be kept constant throughout the test. In automated perimetry, let's talk about the stimulus. Before giving the stimulus, the patient would be given a fixation target, either a central, a small diamond, a large diamond, or a bottom LED, depends upon the test being performed and the patient's ability to fixate. The unit of light intensity is apostolbs and decibels both, whereas the unit of retinal sensitivity is decibels. The light stimulus can be presented in variable intensities using the attenuation filters, and we attenuate the light in log values. The maximum available stimulus for Humphrey is 10,000 ASP units, whereas 1 decibel is 1/10th log unit attenuation of this maximum stimulus. Therefore, by cross multiplication, 10 decibel will be 1 log unit of attenuation, 20 decibels will be 2 log units of attenuation, and so on and so forth. But what does this mean in ASP? It means that 10 decibel unit, there is 1 log unit of attenuation. That means it will be 1000 ASP units. 20 decibel is 2 log unit attenuation, that is 100 ASP units, and 30 and 40 would be so on, and 0 decibels is maximum 10,000 ASP units. Just observe this diagram. 0 decibels is 10,000 apostolbs. 40 decibels is 1 apostolbs. As the decibels are increasing, the apostolbs are decreasing. Therefore, A decibel is directly proportional to retinal sensitivity and inversely proportional to apostolves, and we can say that apostolves is inversely proportional to retinal sensitivity. This would become more clear by this diagram. Whenever we have a low decibel value, it means a high intensity of light stimulus is needed, and that means a low retinal sensitivity is present, and the opposite is also true. Let us talk about the threshold. The light stimulus is defined as the dimmest target seen 50% of the time. A suprathreshold stimulus is brighter than the threshold stimulus and will be seen more than 50% of the time. An infrathreshold stimulus is dimmer than the threshold and will be seen less than 50% of the time. In automated perimetry, let's talk about the background illumination. The background illumination is not the same for all perimeters. In Humphrey, it is 31.5 ASP units and is kept constant throughout the test. Let's talk about the specific points which are tested. In point patterns, there are important considerations. It depends upon the extension of the visual fields tested, the number of the test points, the distance between two points in degrees, which is called the point density, the area around the fixation spot, which is not measured and called the bare area, and the relationship of these points to the axis. In the threshold test, there are certain important point patterns: 30-2 central threshold test pattern, 24-2, 10-2, macular programming test pattern, and nasal. The 30 here means the extent of the visual field tested is 30 degrees, and -1 means that the points are on the axis. -2 means that the points are straddling the axis. 30-2 central threshold test pattern. The number of test points are 76. The point density is 6 degrees. -2 indicates that the points are straddling the axis, and the centralmost point from the fixation spot is 3 degrees, and that 3 degrees is a bare spot. Why is 30-2 preferred? -1 indicates that the points are on the axis. -2 indicates that the points are straddling the axis. Although the point density for both is 6 degrees, the bare area in 30-1 is 6, whereas in 30-2 it is half of 6, that is 3 degrees. Since the bare area is less, the resolution is more, and therefore 30-2 is preferred. If we remove the edge points bearing the nasal 2 edge points of 30-2, we get an octagon shaped point pattern which is called our 24-2. Here in 24-2, the points are spread 24 degrees from the fixation spot. The number of points are 54 and they are straddling the axis. The density and the bare area is again 6 degrees and 3 degrees respectively. Often a 10-2 threshold test pattern is advised when the central points of 30-2 or 24-2 are involved. It measures 10 degrees from the fixation point. The number of test points are 68. The density is 2 degrees and the bare area is only 1 degree in 10-2. Why do we advise 10-2 in advanced glaucomatous cases? In 24-2, we have only 12 points in 10 degrees, whereas there are 68 points in 10 degrees of 10-2. Because of the better resolution, therefore, 10-2 is advised. The macular programming test pattern. It is nothing but the central 16 points of 10-2 in the 5 degree area. The point density is 2 degrees and the bare area is 1 degree. Nasal step threshold test pattern. It is a peripheral test pattern. It provides 2 eccentric central points and 2 points each above and below the horizontal axis at 30 degree, 40 degree and 50 degrees respectively. In automatic perimetry, let's talk about the testing strategy. The full threshold strategy is the standard strategy. In this, the stimulus intensity is varied in steps. First, the patient is given a stimulus. He sees it. Now the light intensity is dimmed by 4 decibels and the process is continued till the patient can no longer see the stimulus. This is represented here by the dark circle. From this point, the intensity is increased now in 2 decibel steps. And the first point where the patient first sees the stimulus becomes the threshold of the test. Since the stimulus is bracketed between the seen and the unseen stimulus and the intensity is varied in steps, this is called the staircase or the bracketing strategy. It provides pretty good accuracy and precision, but it does take a lot of time. The fastback strategy. It is similar to the full threshold. The stimulus here is varied in steps of 3 decibels instead of 4 decibels, and the threshold is crossed only once. Therefore, the time taken is also 40% less, but at the cost of the accuracy. Now, the full threshold is accurate, fastback was faster. The Swedish interactive thresholding algorithm SITA was developed to give us the best of the both worlds. It's a rapidly adapting logical software which adapts to the patient's performance during the test. SITA standard causes 50% reduction in the time, whereas SITA fast gives us 30% additional reduction in the time, and SITA faster takes only 2 minutes per hour. There are certain limitations of SITA. It does not measure the short-term fluctuations or the corrected pattern standard deviation. SITA is not available for macular or nasal step programs also. Now, SITA fast is less accurate than SITA standard at low retinal sensitivities. Therefore, SITA fast should be used only when the patient cannot tolerate longer testing times. With so many testing points and the strategies at our hand, which test do we use for the patient? For suspicious cases of glaucoma, where we want to screen more number of points, we can choose a 30-2. It could either be a full threshold or a SITA standard. In established cases, we use 24-2 central fields, and if it is advanced glaucoma, the selection of tests would be a 10-2 central field. If the field is so advanced and most of the point sensitivity is less than 10 to 15 decibels, or if a macular split is present, then we choose a 10-2 with a size of 5 or a macular program with size 5 stimulus. And this is the summary of the previous flowchart. How to read a Humphreys visual field printout. As you can see, there are 10 zones in the Humphreys visual field printout. We are going to take one at a time. Zone 1 is patient and test data. The patient data is found on the right top of the visual field. The patient data consists of name with ID, date of birth for identification, eye to be examined for the correct eye, date and time for follow-up and for detecting progression over time, age for comparison with the age-matched controls. Also, after 20 years, the light sensitivity decreases by 1 decibel every 10 years. Patient data continued. We should also see the pupillary diameter. 3 to 4 mm size of pupil is optimal. If the pupillary size is less than 2 mm, it can cause diffuse field depression and cause edge scotomas. Visual acuity and refractive error correction is of utmost importance. Refractive error can cause generalized field depression, high-power glasses, and even improperly fitted glasses can give us. The visual field printouts shown here belong to the same patient. They were taken at 2 different times. During the first test, the patient was on pilocarpine, and therefore we can see there were edge scotomas because the pupillary diameter was 2 mm. Whereas when the pilocarpine was stopped and pupillary diameter became 3 mm, even on 30-2, the printout was normal. Here in the first printout we can see generalized field depression, whereas the second printout is absolutely normal. These are the printouts of the same patient who did not have refractive correction during the first test and was given correction and later found to be normal. The zone 1 also consists of the test details which can be found here. It consists of the stimulus size, stimulus color, background illumination, the strategy used, and the point patterns used. Let's move on to Zone 2. The Zone 2 consists of the foveal threshold, fixation target, and reliability indexes. These are fixation losses, false positive errors, and false negative errors. The foveal threshold must always correspond with the visual acuity. Normally, it is more than 30 decibels in 6/12 and above of visual acuity. Therefore, it is serving as an internal validation for the visual acuity. Say, if the acuity is good, but the foveal threshold is low, it indicates an early damage, or it can even be an improper fixation. If the visual acuity is poor but the threshold is good, it means patient needs refractive correction. Fixation losses. During the test, 5% of the stimulus will be presented to the blind spot. If a patient response is positive on such a stimulus, it indicates fixation losses. Fixation losses more than 20% are considered unreliable. When the patient pushes the response button just to the sound of the trigger and not to the actual stimulus, such a response is called a false positive response and the patient is called a trigger happy patient. False positives more than 20% are unacceptable and more than 33% are bracketed. Areas of increased retinal sensitivities will look white on the grayscale and such white scotomas indicate false positive responses. However, sometimes the patient does not respond to the brightest of the stimulus in an area where he previously responded. This indicates a lack of attentiveness and fatigue, and this is false negative error. This error is more than 20% is abnormal, however machine takes it as 33%. So such a patient responds very well to the initial central stimulus, and as the test progresses centrifugally, the patient sleeps off and gives us a cloverleaf visual field pattern. Now let us talk about zone 3. The raw data is the exact retinal sensitivity in decibel units of the selected points. 0 indicates an absolute scotoma and 40 decibel indicates the maximum retinal sensitivity. This raw data, when plotted graphically, forms the zone 4 grayscale. The areas of high retinal sensitivity are indicated by a lighter shade and areas of low sensitivity by a darker shade. Zone 5. This is our raw data, and the deviation between this raw data, that is the measured retinal sensitivity, from the normal retinal sensitivity of the same age group gives us the total deviation numerical plot. The numbers here indicate the amount of deviation. So 0 means there is no deviation, and the symbols, that is positive, will indicate that the point is more sensitive than the normal, and negative indicate that the point is less sensitive than a normal. Zone 6. Each numerical deviation value of the total deviation numerical plot is given a symbol based on its p-value, that is probability, and this will form the total deviation probability plot. In the scale, less than 5% means that it is seen in less than 5% of the normal population, and less than 0.5% means it is seen in less than 0.5% of the normal population and therefore is more significant. Zone 7. The pattern deviation numerical plot is a modified total deviation numerical plot to bring out the deep scotomas. So how do we convert TDNP to PDNP? Let's find out. Step number 1. Find out the 7th best retinal sensitivity point. In this TDNP, it is -6 decibels. Step 2. Convert the 7th best retinal sensitivity point to 0. That means bringing that point to the normal threshold value of the same age group. Step 3. Add the value which was obtained in second step to all the points in TDNP, and finally we get our pattern deviation numerical plot. Zone 9 is a pattern deviation probability plot. It is the symbolic representation of the numerical values of the PDNP. It brings out the localized field defects which are hidden by the generalized. So how do pattern deviation plots bring out deep scotomas? If you remember, in step 3 of conversion of total deviation numerical plot to the pattern deviation numerical plot, we add and elevate the retinal sensitivity at each point. In the process of doing so, the p-value at each point will change. Some become non-significant, some will have some significance left, and some retain their p-values of even less than 0.5%. Therefore, the pattern deviation plot will highlight such points which have retained their p-value of less than 0.5% even after we have elevated the retinal sensitivity by a decibel value which converted the 7th best point to normal, and such points indicates the deep hidden scotomas. Let's talk about the zone 9. It consists of the global indices, the mean deviation, the pattern standard deviation, short-term fluctuations, and the corrected pattern standard deviation. Remember our hill of vision? It has a characteristic height and a smooth contour. The change in retinal sensitivity will affect either of the two, and the global indices expresses this change in height and the contour of the hill of the vision. The mean deviation. It is the average of all the deviation which were present on the total deviation numerical plot, and we express it in decibels along with the p-value. A positive mean deviation indicates an overall better retinal sensitivity than the normal, and a negative mean deviation indicates a worse than average retinal sensitivity. Because mean deviation is derived from the total deviation numerical plot and plus TD and P values were positive, that means had better sensitivity, therefore a positive mean deviation is also better, whereas a minus mean deviation is bad. Also remember that mean deviation expresses the change in the height of the hill of the vision. Pattern standard deviation (PSD). PSD is the standard deviation across the mean deviation index. That means it tells us about the difference among the deviation points which were present in the mean index. So if there's a 0 PSD, it means there is no difference, and therefore the contour of the hill of the vision will be smooth. And if you have a positive value, it means that there is a difference among the point, and that means the contour will not be smooth. So PSD expresses the change in contour of the hill of vision. Here, as you can see, the height of the hill of the vision is affected, whereas the contour is pretty much normal. Therefore, it indicates a high MD and a 0 pattern standard deviation. In this case, the contour is affected, whereas the height of the hill of vision is normal. Therefore, it indicates a normal mean deviation and a high PSD. In this case, both the height as well as the contour is abnormal. Therefore, the mean deviation and the pattern standard deviation both are high. Next global index is the short-term fluctuations. It is assessed by retesting 10 predetermined points and checking the consistency in responses at those points. So it is an index of intra-test variation. Normally, the value of short-term fluctuation is less than 3 decibels. Increased values indicates unreliability and pathology sometimes. When we correct the pattern standard deviation by removing the intra-test variability, that is the short-term fluctuation from the pattern standard deviation, we get what is called as the corrected pattern standard deviation. Zone 10 is the glaucoma hemifield test. Here, 5 zones in the upper field and 5 mirror zones in the lower field of the pattern deviation numerical plot are charted and they are compared. A comparison between the two zones will give us scores, and this difference is compared with the database of the normal population. What is really important about glaucoma hemifield test is that the 5 zones are constructed in approximate patterns of the nerve fibers. Therefore, a GHT can detect glaucomatous field defect at a very early stage. The results of GHT can be given as 5 points: outside normal limits, borderline, general reduction in the sensitivity, abnormally high sensitivity, and within normal limits. This slide revises the location of the important points. That is the grayscale, this is the raw data, above is the total deviation numerical plot, and below is the total deviation probability plot. Pattern deviation numerical plot, pattern deviation probability plot below, the global indices, and above that is the glaucoma hemifield test. So how to classify glaucoma field defect as mild, moderate, severe based on the visual fields? The criteria to label the defect as early are: the mean deviation should be less than -6 decibels. The points which have p-value less than 5% should be only 25% and less than that. And the points which have p-value 1% should be less than 10 points. And no point with a sensitivity less than 15 decibels should be present in the central 5 degrees. The criteria to label a defect as severe are: a mean deviation index of worse than -12 decibels. The points with p-value of 5% should be more than 50%. And the points with p-value of 1% should be more than 20 points. And in the center 5 degree of fixation, any point if it has 0 decibel sensitivity, or in both the upper and lower hemifields we have points which have sensitivity below 15 decibels. And the criteria for a moderate defect lies in between that of the mild and the severe defects. So what do I mean? It means that if we consider mean deviation in the criteria of classification, Mild glaucoma means less than -6, -6 to -12 is moderate, and more than -12 is severe. For the second criteria, we need to look at the points with p-value of 1% and p-value of 5%. So if the points with a p-value of 5% are fewer than 25%, it is mild, 25% to 50% is moderate, and more than 50% it is severe. And the points with p-value of 1%, if there are less than 10 points, it is mild, 10 to 20 points is moderate, and more than 20 points is severe. The central 5 degrees is also considered for classification. If there is no point below 15 decibels in this 5 degrees, it is mild glaucoma. If there is 1 point less than 15 decibels either in the upper or in the lower 5 degrees, it is moderate glaucoma. Even if there is 1 point of 0 decibels or there is 1 point each of less than 15 decibels in upper and lower field, it becomes severe glaucoma. This brings us to the important criteria for detecting early glaucomatous field defect, which is the Anderson's criteria. It has 3 main points. Number 1, 3 non-edge adjacent points in the pattern deviation probability plot, of which at least 2 points should have p-value of less than 5% and 1 point should have p-value of less than 1%. Number 2, the corrected pattern standard deviation p-value should be less than 5% and the glaucoma hemifield test should be abnormal. This criteria should be met on at least 2 occasions for it to be called positive. This slide highlights some of the important named scotomas. In the picture A, it highlights the Jerem's area, which is located 25 degrees from the fixation, and the blind spot, which is located 10 to 15 degrees temporally from the fixation. In the picture B, we have a paracentral scotoma. In picture C, the paracentral scotoma mixes with the blind spot and forms the Seidel-Sickles scotoma. In point D, we have the arcuate or the Jerem scotoma, and then we have a double arcuate ring scotoma with a Rennie's central nasal step. This picture shows the nasal step and the temporal wedge. After this, in this field printout, the reliability is good. The glaucoma hemifield test is outside normal limit. The TDPP and PDPP, both of them are showing identical field defects in the upper and the lower nasal quadrants, and therefore this is an example of nasal step. In this printout, the reliability is good. Mean deviation is abnormal, -13. Pattern standard deviation is +14.51. Glaucoma hemifield test is outside the normal limits. And we can see that in both the TDPP and in the PDPP, identical field defect is present in the arcuate pattern in the lower field. It indicates a lower arcuate scotoma. In this patient, there is a good reliability. The mean deviation is -30.34 decibels, which is really high. Pattern standard deviation is +6.24. GHT is outside normal limits. There is generalized depression seen in the total deviation plot. And we can see that the Anderson criteria is being met along with center involvement. It is advanced glaucoma and therefore we advise 10-2. In 10-2, we can see that there is still good field remaining around the fixation and there is no macular split. Another case, here the fields are reliable. The mean deviation is -9.4. Pattern standard deviation is 7.67. P-values for both is less than 0.5%, which is significant. Glaucoma hemifield is outside normal limits. There is a generalized depression on the TDPP because of the cataract seen clinically, and this dense lower arcuate scotoma in PDPP. That means this is a case of cataract with glaucoma. For this patient, the fields were reliable. The mean deviation index was significant. The GHT showed that there is general reduction in the sensitivity, and there was generalized depression in the TDPP, and the pattern deviation probability plot was normal. So this was a case of cataract. In latest perimetries, we have the short wavelength automated perimetry, SWAP, also called the blue-yellow perimetry. Here we use a blue object on an intense yellow background. This causes bleaching of the red and the green pigments and isolates the blue cone system, which is affected much more earlier in glaucoma. Therefore, this is much sensitive test than the standard white to white perimetry, as that detects a field loss when about 40% of the retinal ganglion cells are affected. The frequency doubling technology. The retinal ganglion cells are divided into two types, the parvocellular cells and the magnocellular cells. The parvocellular cells respond well to high spatial frequency, that means fine details. The magnocellular cells respond to low spatial frequency, that means broader patterns. The P cells again respond to low temporal frequency, that means low flicker rates, and magnocellular responds to high temporal frequency, that means fast stimulus rate. In frequency doubling technology, we are testing the special type of magnocellular cells. Here, alternate light and dark bands, that is, low spatial frequency, is presented to the patient at really high temporal frequency rates, and this leads to the patient seeing twice the number of the dark and light bands than what is present. That means the patient has a frequency doubling illusion. And this is the principle of the frequency doubling test. That is, the nonlinear response of the MY cells to the change of contrast converts the low spatial frequency sinusoidal gratings as it undergoes high temporal frequency counterphase flicker to a frequency doubling illusion. When we interpret the visual fields, we should always correlate clinically. For example, in this field, there is a superior arcade defect on PDPP and TDPP both, and even the indices are suggestive. But when you do the disc examination, there is disc coloboma present inferiorly. Similarly, here also we can see an inferior defect in the TDPP, also in the PDPP. Again, the glaucoma hemifield test is outside normal, and it comes out to be a case of superior temporal BRVO. This patient came with a superior altitudinal defect, and on disc examination there was pallid disc edema, and the other eye showed the disc at risk. This was a case of AION. In the next case, the right eye showed superior temporal defect. The optic disc was normal. The left eye showed a diffuse vision loss, and the disc showed a pale rim and a shallow cup. Since the patient was young and there was asymmetrical changes in the disc and the visual field, it prompted the clinician for neuroimaging, and it indicated lesion at the junction of the optic nerve with the chiasm, and this was an example of junctional scotoma. The next case, the visual fields of a middle-aged man who was also myopic indicated bilateral centroscleral scotomas. And on disc examination, there was tilted disc in both eyes with temporal pallor and myopic crescent. On further investigation, this patient was found to have family history of similar complaints and was later classified as autosomal dominant optic atrophy. This is a visual field recording of a middle-aged lady who presented with diminished vision and color vision defects. It shows inferior altitudinal defect and superior scotoma with center involvement. The disc examination showed optic atrophy, and on neuroimaging there was tramtrack sign and target sign suggestive of nerve sheath meningioma. Finally, what is the take-home message? Always get the fundamentals right. Take a thorough history and correlate clinically. Do not rely on a single piece of information. Keep an open mind. Every field defect is not glaucoma. A patient can have more than one disease. And with my references, I conclude my slide. Thank you.